What's up, guys? I'm Brett Kelly, and today I want to talk about your options you have after you realize you've torn your ACL. So a little bit about my background. I worked as a strength conditioning coach in the pro and college settings for over 15 years. Currently, I'm working with Exos. Before that, I was working with the U.S. ski team where I did tons of ACLs with Olympic and pro level athletes that were just rehabbing from skiing and snowboarding injuries. So it's kind of become a passion of mine over the course of the last 10 years. And now I do a lot of online training where I work with people, connect them with physical therapists, whatever it might be, to help them get back to where they want to be and just achieve whatever goals they have. So usually that first step is figuring out, first off, who your ortho is going to be, and then really what that surgery is going to look like. There is the non-surgical route, obviously. For some people, that can be an option. Really, that's going to be dependent on if you're symptomatic, meaning if your knee is giving out or not, or if your tendon is fully ruptured, or ligament is fully ruptured or not. So this isn't always a good option for most people because most people do have symptomatic issues. Their knees swelling, they're buckling, it's a full tear, that kind of things. But if you're lucky, that might be an option for you. So go ahead and consult with your physician on that. And then also the bear procedure or the ligament repair procedures. That's another option that some people get. Again, it's going to be very specific to the type of injury you have. So if that ligament is pulled basically off the bone or that tear is very close to the bone, they can do a procedure where they basically build kind of like a suture between them or scaffolding, and then they'll put almost like a blood clot on there to help that heal up itself. Okay, so you can heal. You can potentially go on an athletic career without an ACL altogether. It is very rare, but it can happen. That being said, 95% of people I've worked with, or even higher than that maybe, do need some type of surgery, some type of repair to actually get back to where they want to be competitively. And for them, it really comes down to a handful of different grafts. So we have allograft and we have autografts, okay? So for allografts, those are going to be typically like your cadaver grafts. Research has shown that those are generally about 4 times more likely to re-tear. So as far as the strength goes, you have first off the rejection factor. You're putting something new into your body from an outside source. Your body might reject it. Typically, we don't see that, but we do see a lot higher risk of that re-tear rate. The pros when it comes to the allograft, if you're not, potentially a competitive athlete, you're not that worried about that re-tear, is it's going to be a lot easier of a rehab process because you're not taking part of your knee out to replace it with another part of your knee. And I'll explain that kind of as we talk about these next graphs. But it gives you a little bit less to have to rehab, basically. So that's that allograft. Now when we get into autografts, we're talking about taking a part of, again, your knee, whether that be that same knee that you injured or even the opposite side, and utilizing that for your new ligament. So the big ones we have is the hamstring graft. They'll go in, they'll actually scrape part of your hamstring, semitendinosus, and they'll take part of that tendon, they'll twist it up, turn it into a ligament, and they'll drill a hole back in your knee, put that through there, suture that back down in some capacity, and that'll be your new ligament. So that, for a long time, was kind of the main one. More recently, people are starting getting into patella and quad tendon grafts. So patella and quad tendon grafts are going to have usually a little bit lower risk of re-tear, higher strength than the hamstring graft because they're going to have some bone attached to it as well. So the hamstring is just fully tissue. So the re-tear rate's a little bit higher than the others. And you're going to have potential issues with hamstring strength, hamstring strains. I usually see more or less just a lot of cramping even years after, unless they're doing a lot of isolated hamstring work. So you're going to have to make sure you address that properly throughout the whole time, okay? And even, like I said, years after, because you might just have that cramping back there, that weakness back there a little bit. Usually it's nothing that you can't, still get back to those same numbers as far as strength and power goes, but it's just something you have to think about going in, okay? One of the pros is you're not going to have as much of that anterior knee pain. So with the patella and with the quad, the front of the knee, you're going to have more of that anterior knee pain. Specifically with the patella, they're actually going to go down to the bottom of your knee. They cut a little piece of bone out from your patella tendon, and they'll take it all the way up into that kneecap. They'll take that out, so it's bone. It's a little bit of that ligament or that tendon, and then they'll put that into your knee again, and you'll have those bones on each side because those were cut out, and those are going to be put through your knee. So now it's sutured. And where the suture is, there's actually a little piece of bone from your patella graft too. So that bone heals to the other bone in the holes, and you're inevitably going to have a stronger graft site there. So that's going to be a little bit stronger of a graft for sure, but you do have that now deficit in the front part of your kneecap, and you can kind of get that feeling of that patella tendonitis. So if you ever had like jumper's knee, that's kind of what that feeling is going to feel like longer term. I see that with a lot of people with ACL injuries, but with the patella and sometimes with the quad tendon graft, I'll see that linger a little bit longer. So if I have a hamstring graft, I might have anterior knee pain for, 3, 4, maybe 5 months. If I have the patella tendon graft, that can sometimes linger up until the 8, 9, 10 month mark, and I'm still having some knee pain there. It's not anything we can't work through. It's just something we have to know and be cognizant of, and it's something we're going to have to address in that rehab process. But it's a stronger ligament stronger new ligament, so it's going to be a little bit probably better in that sense. Now, the most recent one, at least, besides the Bear procedure, which is the repair, most recent graft site is going to be that quad tendon graft. So again, they go through, they actually take out part of the quad, which is, obviously one of the larger muscles when it comes to like the hamstring or the quad. Quad's gonna be a little bit bigger, a little bit stronger, so that's why it's a stronger graft. It's not in the lower part of the knee where you have a lot of that anterior force when you're squatting or lunging, so you don't have as much anterior knee pain as the patella. So this is kind of why it's become this new wave of potentially something that can be that new best thing. But it is relatively new. I first started seeing it probably 7 years ago. It might have been, around before that, but that's just when I first started seeing it. I'll be honest. The first couple I saw, I did see a lot of quad atrophy, so muscle wasting, right? Which we see with every surgery, but a lot of times that'll come back relatively quickly. And with the athletes I worked with, it was a little bit more challenging. So it was harder to get that quad back to the size it wanted to be before. Now, I was also working with skiers. Skiers are extremely quad dominant. If you ever skied before, you're told to put your shins in the front of your boots, so your knees are kind of always almost over your toes, and you're using all your quads. So for them, they're so quad dominant that I don't think it was necessarily a great surgery choice specifically for a skier, right? If that's your main sport. But everybody I've worked with outside of skiing, it's been a very, very good rehab process, very few complications, and very few re-tears. So, in my mind, I feel like I would still potentially go, it depends on, I guess, your background in other injuries. But for me, not having, knock on wood, any other knee injuries, I would probably go patella just because it's been around longer and I've seen what needs to be done to make sure that anterior knee pain goes away. But now I'm starting to lean more quad graft for sure. So at the end of the day, not trying to talk you out of doing any one or the other. I think they're all very good options for you, and I think it really is going to be dependent on your physician. Okay, so find a physician that you really want to work with and make sure you're talking with them. They're going to have a lot more experience than me, and then obviously you as well on the subject, and they're also going to have something that they favor overall. And at the end of the day, if I trust my physician and their experiences and the people that they've worked with and the surgeries that they've already done, I'm probably going to go with whatever they think is best and whatever they're most comfortable with as well. So, have that knowledge in your back of your head going into it of what you may or may not want or what kind of questions you may want to ask your physician. But at the end of the day, if you trust that physician, they're going to probably have what they think is best based on the situation. So just talk through that. And if you guys have any questions, feel free to DM me on here. If you enjoy this, go ahead and subscribe or share. Thanks.